Welcome. Today we are going to learn how to perform extension block pinning for mallet finger. Mallet finger injuries usually occur during sports related activities as there is a predisposition to these injuries during participation in ball sports as the ball hits the fingertip of an extended finger. This compels the distal interphalangeal joint into a forced flexed position and thereby causes an extensor tendon disruption. Most often, such injuries involve the long finger, the ring finger, or the little finger of the dominant hand. Loss of extension at the distal interphalangeal joint leads to formation of what is known as the baseball finger or mallet finger or drop finger. Now it can be divided into a soft tissue mallet finger in which there is only rupture of the extensor tendon in zone 1 and a bony mallet finger in which there is an avulsion of the extensor tendon from the distal phalanx along with a small fragment of bone attached to the avulsed tendon. Now surgery is controversial in a closed acute mallet finger, but it can be done in all open injuries. Injuries with large bony mallet finger with subluxation of the joint, fractures involving 30 to 50% of the joint surface, and people who are intolerant to splints. Now, a 25-year-old male presented with history of formation of a mallet finger while taking a catch with a cricket ball. Here you can see the typical deformity. 45-degree flexed, and once we did the x-ray we found that he had a bony mallet finger and the patient was intolerant to splint, so we decided to go for surgery. So now I shall demonstrate the procedure of extension block pinning. So we have to determine the precise location of the distal interphalangeal joint under a C-arm, so as to put our first K wire which will work as our extension block. So this wire that I'm using will be a 1.2 mm wire, and here you can see my aim would be to be a bit proximal to the avulsed bony fragment, and with the help of a C-arm, here you can see I'm just putting my K wire on the, here you can see I've located the bony fragment. I'm just a bit proximal to it, and I shall now enter the skin, and here you can see just I'm on the bone, and this will be a correct position, and with an angle of around 45 degrees uh, the K wire is driven through the cortex and into the middle phalanx. This K wire will serve as the extension block K wire. This will prevent the dislocation of the dorsal fragment. Now with manual traction you can see this will be preventing the dislocation of the dorsal fragment. So now I'll put my second K wire that will help in joint transfixation. The axial wire I'll put through the distal phalanx from the tip of the finger, and I'll drive it through the distal interphalangeal joint. That will help in joint transfixation. So my both the wires are in, and here you can see that the mallet finger has been corrected and the avulsed bony fragment has been blocked. So now I'll bend and cut the wires. So I used a 1.2 wire for extension block pinning and 1.5 wire for joint transfixation. So this will be a 1.5 wire for joint transfixion which I am bending, and I'll cut. So the wires have to be cut such that it protrudes through the skin, and one has to bend it like to form an L configuration so that the K wire doesn't catch on the clothing. So the tip of the pent wire can be rotated. So this is the C-arm view that we got after bending of the K wires, the AP and the lateral views, and these are the post-op x-rays of the same patient. Here on the left side of the screen you see the initial mallet finger in which there was a avulsed bony fragment, and the lateral view post surgery and the AP view post surgery. You can see that they have been beautifully reduced and put back in place. So this is the view of the finger from the side, before surgery you can see the mallet finger deformity, and post surgery you can see that the deformity has been corrected. This K-wire was put for around 8 weeks, and after removal of the K-wire you can see the X-ray on the left hand of the screen. You can see that the fragment has healed well and it has united with the parent bone, and the patient had a good functional outcome and a good range of motion. I hope you enjoyed the video. If you did, kindly like, subscribe and comment. Thanks for watching.